Assalamu alaikum. Now I would like to discuss about stridor. Stridor may be acute, may be chronic. If it is acute, think about croup and foreign body aspiration. Croup is caused by the parainfluenza virus. Acute laryngotracheobronchitis, parainfluenza virus. Most cases in fall and winter, croup, parainfluenza virus, croup, biphasic, strad, croup, biphasic, strad, or barky cough, croup, biphasic, strad, or barky cough. Parainfluenza usually happens in the premise, and palivizumab is the drug of choice. Okay, foreign body aspiration, choking episode, foreign body aspiration, choking episode, and inspiratory stridor. Inspiratory stridor. So croup is biphasic stridor, and foreign body aspiration is inspiratory stridor. Now laryngomalacia, which is chronic, floppy supraglottis 4 to 8, floppy supraglottis 4 to 8. And laryngomalacia, there is inspiratory stridor, worsens once feeding, crying, or supine, improves when prone, worsens when supine, improves when prone. Vascular ring, V for vascular, B for biphasic. So biphasic is croup, biphasic is vascular ring, and improves when neck extension, improves when with neck extension. Vascular ring compresses trachea. Now, airway hemangioma. Hemangioma is a dilated hemangioma is the benign tumor of the blood vessel. Hemangioma, airway hemangioma enlarges in the first few weeks of life. In airway hemangioma, there is biphasic stratum, and skin hemangioma looks like beard appearance. So, A is B, airway hemangioma biphasic stratum. B is again B, biphasic stratum. C, before B. So croup is biphasic stratum. Foreign body aspiration is inspiratory stratum. Laryngomalacia is inspiratory stratum. These are the words you need to remember for a patient with stratum. Now tracheal stenosis or tracheomalacia. Weakness and collapsibility are complication of prolonged endotracheal intubation. It happens when prolonged endotracheal intubation, tracheal stenosis is associated with prolonged more than 2 weeks of mechanical ventilation. Presence with slowly progressive rather, rather than episodic dyspnea and potentially accompanied by expiratory stratum. So tracheomalacia, expiratory stratum, laryngomalacia, inspiratory stratum. You need to remember this. Adolescent boy vectoral presenting. Adolescent boy vectoral presenting with subacute cough accompanied by stridor. Expiratory stridor, force vital capacity, slow slow vital capacity, and a second outflow volume loop, all of which are associated with tracheal collapse. So key idea like force vital capacity, amount of air that can be forcefully expired is almost always equal to slow vital capacity, with once exception is tracheal collapse because forceful expiration leads to obstruction, less air is expired. Now look at this vocal cord dysfunction, also that is paradoxical closure during inspiration. Paradoxical closure during inspiration can present with intermittent dyspnea, noisy breathing, vocal cord, noisy breathing, inspiratory stridor, triggered by exercise, psychological stress. It is more common in young women. It is more common in young women. Vocal cord dysfunction. Inspiratory stridor triggered by exercise or psychological stress. It is more common in young women. Diagnosis is laryngoscopy showing vocal cord adduction during inspiration. Vocal cord adduction during inspiration. Acute episode sniff of sniff or pant, which activates the posterior cricoarytenoid wall to abduct the vocal cord. Non-invasive positive pressure ventilation. Endotracheal intubation ideally should be avoided. Now, long-term treatment, education therapy, speech language pathologist. So, velopharyngo, velopharyngeal insufficiency is a common sequelae in cleft palate. Inability, it is defined as inability to properly close the velopharyngeal port separating the nasopharynx and the oropharynx during the production of the speech, which is frequently caused by shortened palate, persistent palatal defect. And VPI is high pitched hypernasal whistling speech and intelligence in reduced intelligence. Okay, or now laryngomalacia, where there is inspiratory struggle. This is the picture of the laryngomalacia. This is the site of inspiration. Mild collapsed arytenoid. So there is floppy larynx collapse and turbulent airflow causing the stridor. So laryngomalacia, inspiratory stridor, worse when spine. Laryngomalacia, inspiratory stridor, worse when spine. There is collapse of supraglottic tissue. This supraglottic tissue is collapsed on inspiration. Peak at 4 to 8 months. Laryngoscopy show omega shaped epiglottis. There is omega shaped epiglottis. Laryngomalacia reassurance with close follow-up concurrent with GR treatment and supraglottoplasty for severe symptoms. Now, laryngomalacia, floppy supraglottic structure that collapses during inspiration due to laryngeal hypotonia. However, it presents in infancy that resolves by age 18 months. How to confirm fiber optic laryngoscopy should be used for laryngomalacia. This is the picture. Torus palatinus, hard immobile mass. This is torus palatinus, hard immobile mass on the hard palate in young children. Benign bony growth can increase in size throughout the life. No medical or surgical therapy is needed until symptomatic. It can be congenital or develop in the later life. Okay, that is all about laryngomalacia and stridor. Hope you enjoyed.